medicine 1. My patient is Mr. MS, a 62-year-old man who presented with constitutional symptoms and a left lower zone lung cavity and significant mediastinal adenopathy in 3. At that point, the first differential we considered was tuberculosis, and a biopsy from this was traced expert positive, RIF indeterminate. Biopsy showed extensive necrosis with features suggestive of a tuberculous granuloma. However, we didn't have any microbiological proof, but because of the clinical presentation as well as the suggestive histopathology, we started him on first line ATT on the 26th of March. He came back about 4 months later with 3 months of recurrent fevers and loss of appetite, and he had lost about 1 kilo of weight. So we redid an imaging which showed stable mediastinal adenopathy. The cavity was still there, although the wall had thinned out a little bit. So we verified drug compliance, did another biopsy which showed foci of necrosis with histiocytic aggregates and mild chronic inflammation. Again, we did not find any microbiological evidence of TB. We ruled out other fungi and malignancies as well. So we did, because we needed more objective evidence of drug compliance, we did therapeutic drug monitoring of his rifampicin and isoniazid, which showed suboptimal levels of rifampicin. So we hiked the dose from 600 to 750 at that point. He went back home in September, came back in October. His symptoms were actually fatigue and vomiting for a week. He went to a local chest X-ray and said, there is a problem, go back to CMC. Now, comorbidities wise, diabetic, hypertensive, and never a smoker, CKD secondary to diabetic nephropathy. This was his chest X-ray when he left us in September. Okay, and this is his chest X-ray when he came back in October. So the timeline is March we started ATT, August he came back again with constitutional symptoms and some weight loss, and October he's come back with a left massive pleural effusion despite being compliant on first line ATT all this time. Examination wise, he was vitally stable, no significant adenopathy, and features of respiratory system examination were consistent with the left pleural effusion, massive pleural effusion. He also had features of diabetic neuropathy. So summary, this is a patient with chronic fever, constitutional symptoms, detected to have a left lower zone lung cavity and mediastinal lymphadenopathy, diagnosed to have pulmonary tuberculosis based on the clinical syndrome and suggestive histopathology, and started on first line ATT, now with a new left large pleural effusion. Sorry. So why is he not getting better is our question. So we start here. Is it TB? It's not TB. We had reasonably ruled out quite a few differentials. I'll come to the results. Other granulomatous diseases with pulmonary involvement and constitutional symptoms we considered were histoplasma, MAC, nocardia, sarcoid, RA, ANCA vasculitis, lymphoma with sarcoid-like reaction, histiocytosis X. Many of these clinically itself didn't fit the profile of patients that are involved. And less common causes of left-sided, isolated left-sided pleural effusion that were to be considered were pancreatitis, esophageal perforation, and aortic dissection. Esophageal perforation was a possibility because he was vomiting continuously the week before he came here. Now, considering that it is TB, is he compliant with his medications? Is he taking the medications correctly? Yes, both were verified. We had adjusted doses based on our therapeutic drug monitoring as well. He didn't have any malabsorption that could suggest poor absorption of these drugs, and he wasn't on any interfering drugs that would interfere with cytochrome metabolization of rifampicin or isoniazid. Then is it MDR TB? We don't know because we don't have a microbiological proof. We never had culture growth. Even then, if it's not all this, why isn't he getting better is our question. So, okay, so in interest of time. So, differentials for non-TB granulomatous disease, immunodeficient states with TB, primary immunodeficiencies are unlikely at 62. Acquired immunodeficiencies we could consider would be HIV and anti-interferon gamma antibody syndrome, which is called adult onset immunodeficiency. But he didn't fit that phenotype. They present like an advanced AIDS complex. He didn't fit that phenotype. So this leaves us with what we finally considered most likely in him, paradoxical worsening of tuberculosis. So he had these are his summary of investigations. He has an anemia, normocytic pneumochronic of chronic disease, CKD, a mild cholestatic hepatitis, an elevated CRP, an exudative pleural effusion, and HRCT showed a massive left pleural effusion. This histoplasma, ELISA, ANCA, ACE, all were normal. BBVS was negative. This is the summary of all the biopsies he underwent, and all of them have shown necrosis of varying grades with granulomatous inflammation, and never have we found fungi, AFB, or malignancies in any of his biopsies. So we did a basic immunodeficiency workup that was also negative. Immunoglobulin levels were normal. CD4 was mildly decreased, but he has an active immune phenomenon and his percentages were okay. So this is just his PET CT that is showing in August, which is still showing uptake in his mediastinal nodes. And what you see on the last image is that left lower lobe lung cavity in the green, which is not as avid. And this is his thoracoscopy now, which is showing a classical sago grain appearance, multiple tiny pleural nodules, which are suggestive of granulomatous inflammation. So his diagnosis is probable paradoxical worsening of pulmonary tuberculosis with diabetes, hypertension, CKD, and anemia of chronic disease. We have inserted a drain, an ICD, intercostal drain, to drain the massive left pleural effusion, and he's planned for a course of steroids. I'll just touch upon a little bit about paradoxical worsening. Basically, paradoxical worsening is clinical or radiological worsening of pre-existing TB with new lesions or worsening of prior lesions in patients who initially show a response. It is classically described in immunodeficient patients, HIV positive people, but actually it can occur in immunocompetent patients also, because there is a spectrum of immune reactions to TB even in normal people. It can occur at any time during the course of ATT or even after ATT is completed. And the difficult thing in paradoxical reaction is differentiating it from drug non-compliance, MDR TB, especially in cases like this where we don't have a microbiological proof. This is the criteria of diagnosis, which is from this paper by Jerry, which is basically the same thing we discussed on the previous slide. How common is paradoxical worsening in pulmonary tuberculosis? In HIV uninfected patients, 2 to 23% can have paradoxical worsening. So actually in people who don't respond to ATT as we expect them to respond, we must always have paradoxical worsening at the back of our mind. CNS TB, lymph node TB, and pulmonary TB are common sites for paradoxical worsening, even if the primary tuberculosis is elsewhere. And the outcome of TB iris in thoracic TB is pretty favorable, 95% recover fully. It can either present as new parenchymal lesions, lymphadenopathy, or endobronchial lesions, and it can occur on either side. And my last slide is on management. So basically, there is no consensus on management. You continue ATT. Some even extend ATT, and there are reports for ATT given up to 27 months for improvement of the paradoxical worsening. There is some evidence for systemic corticosteroid use as well, especially in space-bound lesions like tuberculomas and endobronchial obstructions to decrease inflammation. So my learning point is to always consider paradoxical worsening in people who don't respond initially who have responded to ATT. Thank you.
Any questions? One question.
We will repeat on 25th October, sir. We are planning to. We need to, one steady state of observed rifampicin is what we need, sir. So 25th of October, that's planned.
Okay.
Large response facing paradoxical worsening, the whole thing is.
So the basis of your diagnosis was that trace positivity
and the
for expert
histopathology
PCR.
with the clinical syndrome, ma'am. He came with some constitutional features and he had granulomas with extensive necrosis on the histopathology. So with that, the first differential would be TB. But we never got an organism. We don't have a microbiological proof.
This necrotizing granulomatous inflammation we can get very well in other diseases like ANCA vasculitis and all.
We had ruled those out.
Yeah, I know. ANCA negative, but there is a proportion of patients. ANCA positivity is generally seen in up to 60% of the patients.
Yes.
Lung, it is a little higher, maybe up to 80, but there are another 20% of patients who are not present with ANCA.
But pleural effusion in,
yes, it can happen. Any of these complexes can happen over time.
Okay.
Anyway, if he responds to steroids, you do not know whether. Okay, thank you.
Thank you.